Good evening, everyone. I'm Nureen Mustafa, Head of Clinical Oncology at Ain Shams University Specialized Hospital. It's my great honor to be with you today, and would love to thank all Amgen team for inviting me for this symposium tonight, and thank you for all the attendees for sharing their time to attend this symposium at the end of this long, heavy, rich day. Thank you so much. Tonight, the title of the talk will be the role of manitumab in the management of metastatic colorectal cancer. Sorry, معلش بس أيوه. Colon cancer. Excuse me 1 minute. My friend Dr. Ala Jamil, the chairperson of the session, will come. Starting the talk about the global perspective of colorectal cancer and the burden of the disease. As we all know that colon cancer now accounts for the third common cause of cancer among women and men, and it's the second most common cause of cancer between men and women. And as we all know that there is a global trend towards increasing the cases of colon cancer due to a lot of lifestyle habits, increasing the obesity, increasing the junk food, lack of exercise, increase the awareness and screening, which leads to increasing the incidence of cancers. And by the recent statistics that by 2040, there will be increased more than 40% of the cases in young age, less than 40 years old, and the appearance of the early onset of colorectal cancer. Colorectal cancer therapy, as we all know, that now the best treatment management for the cases of colon cancer to be managed in multidisciplinary team. Multidisciplinary team, which includes the medical oncologist, the radiation oncologist, the colorectal surgeon, and the hepatobiliary surgeons, the pathologist, and specifically the molecular pathologist, the nurse practitioner, the nutritionist. All of them are important in management of colon cancer. It's now not one size fits all, but now we are in the era of precision medicine, and we are having tailoring treatment for every patient. And recent studies have found that there is significant increase in the survival for the patients who are treated in multidisciplinary settings other than patients who are treated just by one specialty. The drivers for the first-line treatment. Now, as I said, that it's the era of the individualized treatment, precision medicine. We have many factors that are depending on the treatment. Tumor characteristics, we all know that the clinical presentation of the patient is it presented with stage 4, or it is stage 1, 2, 3, and then progressed metastasis along the history of the history of the patient, the tumor biology, and the molecular markers. Patient characteristics, the age of the patient, definitely the old or frail patients than younger patients. As I said previously, that now we are all observing the new trend of having new colon cancer patients in younger patients that are younger than 40 years old. The gender, now the recent data have found that the gender affects the prognosis and even though the prediction to treatment and the side effects of the treatment. Performance status, the organ function, if he has other comorbidities, liver function, renal function, diabetic, which will, depending on the choice of treatment and the side effects of the treatment, and the treatment characteristics of toxicity profile, we all found in our practice that the patient, the first common question that asks is what will be the side effects of the treatment and the flexibility, availability of the treatment. And on this occasion, I would love to say that now the targeted therapies, the anti-EGFR, are available in the Ministry of Health protocols, and the RAS testing is available all for free. There are multiple differences between the right and left colon. As we said that the tumor now, even though the sideness of the disease affects the prognosis and the prediction without treatment. Even though embryological organs, the midgut differs in the head gut, the function of the colon differs from the side than other parts of the colon. Metabolism, fermentation, degradation, almost inactive metabolically waste reservoir at the distal parts of the colon. The microbiome now, the recent era of the microbiome and the use, the etiology of the colon cancer or its uses in the treatment of the colon cancer, as well as genetic and epigenetic wise for the colon. Right and left-sided, and this was the first disease that had discussed and addressed the issue of the sidedness and its impact on prognosis and prediction. Due to different factors, we have found between the right and the left sided of the colon, the presentations in the right side are more common in the female versus males in the left common side. The percentage, even the incidence in the right side is less, fortunately, due to its poorer prognosis that has been found in the studies. Fortunately, it has less incidence than the left-sided, which is more common, 60 to 80%. Genetic predisposition differ from right to left side, and the presentation, and even though the age presentation has been found that the older age is presented with right-sided, and in contrast to the left-sided, which is more common in the younger patients. The current guideline, the precision medicine, is now depending on the molecular marker. So the molecular marker testing and the full colon panel markers is mandate in the treatment of our colon cancer patients. The RAS testing should be carried in all patients at time of diagnosis due to its prognostic and predictive impact. The HER2 amplification testing is also important. The BRAF mutation of BRAF testing, the MSI and testing, as we all know now that we are having a new card in the treatment of our metastatic colon cancer patients, which is the immunotherapy. And in the studies of the metastatic colon cancer, discovered testing rates of 41%, 33%, 51% for the RAS, BRAF, and MSI respectively, in comparison to the adenocarcinoma non-small cell lung cancers that found testing rates of 94%, 95%, and 88% for the ALK-EGFR and ROS testing. So overall, biomarker testing remains suboptimal, and adherence to guideline recommendation testing could potentially reduce the exposure to ineffective therapy and will improving our patients' outcomes. This slide shows the NCCN guidelines for the metastatic colon cancer, and we all know the NCCN guidelines, and we follow the guidelines in our practice, and showing that the initial therapy is based on the full molecular marker testing. And according to the results, definitely if we are having the RAS wild type, definitely we should go for the anti-EGFR therapy combined with the fluoro-based and oxaliplatin-based if patient fit partner for the anti-EGFR. And for the MMR deficient patients, we will go for the immunotherapy. If patient is fragile, old patient, not fit for intensive therapy, we can go for the single agent plus or minus anti-EGFR or anti-VEGF therapy. And this slide shows the preferred initial therapy for metastatic colorectal cancers who are appropriate for intensive therapy, who are showing good performance status, good tolerance for the therapy, where high tumor response rate is potentially beneficial. We will go for according to the molecular marker testing results for chemotherapy plus anti-EGFR, or if we don't have, we are having mutation for the molecular marker testing, we will go for anti-angiogenesis markers. If we are having the MSI stable, we will go for the immune checkpoint inhibitors. The three main game players for immunotherapy: pembro, nivo plus or minus epi, and dostarlimab. Now, why we will go for anti-EGFR as first-line treatment for wild-type RAS test? I know that all the attendees are oncologists, and we are, as oncologists, know the most important endpoint for any trial and most important or crucial endpoint for any study that we go for is the overall survival benefit. And we are having now the double-blinded randomized phase controlled trial, multinational phase 3 trial, PRIME trial, which tested the addition of, excuse me, sorry for the slide. Excuse me. The PRIME trial. Okay. Okay, sorry for my technical ignorance. For the double-blinded randomized phase 3 international trial that was well designed and well balancing the patients between the two arms, the arm which contains the standard of care at that time, the chemotherapy for FOX4 protocol, plus the anti-EGFR panitumumab versus chemotherapy and placebo. And this trial was very well designed that it covered most of the countries, most European, Asian countries, that was well balanced geographically and have a high number of patients, 1,183 metastatic colorectal cancer patients. The primary endpoints were the progression-free survival, the overall survival, and the overall response rate, safety, and quality of life. The initial results of the trial was significantly positive regarding the progression-free survival in the favor of the panitumumab plus FOLFOX, 10 months versus 7.9 months in the FOLFOX placebo arm, and the updated and prolonged analysis of the trial strongly, significantly showed positive regarding the overall survival benefit for the panitumumab FOLFOX arm, 26 months versus the FOLFOX chemotherapy protocol arm only. Another important point or characteristic for metastatic colorectal cancer patients, the patients who are, even though presented at stage 4, we can still aiming to cure this patient. And I think it was the first disease area that we are having stage 4 presentation and still we can cure our patients. And we are having the early tumor shrinkage with the wild type RAS patient with the panitumumab FOLFOX arm, that the early tumor shrinkage was in more than 20% at week 8 for 72%, which is very high percentages, against the FOLFOX arm, which was 57% only. And also in the prolonged duration of our patients and after the evaluation, at week 8, more than 30%, which is very, very big response, that we are having more than 30% of the patients having a good response and showing partial response, were in 59% of the patients. We know that this patient could be presented with impending obstruction, and we sometimes in the MDC, shall we go for surgery, shall we go for systemic therapy? And definitely if we are having a line of treatment that could have a very good quick response, that will not make our patients delayed in the systemic therapy, that we are sometimes afraid not only from the presentation of metastasis, but we are afraid more of what we couldn't see, the micrometastasis. So to go for initial systemic therapy or downsizing for our patients and not to delay them for sake of surgery to avoid obstruction or complications, definitely will have a very good weapon for our patients. Another phase 2 trial peak study that comparing also the modified FOLFOX6 plus panitumumab versus FOLFOX Viva, according to the wild KRAS type, that as we said that we are now having a multiple monoclonal or targeted therapies, and we are comparing them in this peak 2 phase 2 trial that showing the study endpoints, progression-free survival, overall survival, and overall response rate, safety, and quality of life. It confirmed the same results, that we are having early tumor shrinkage, more than 30%, which is very big tumor response, as well as the median duration of response. We are having long, sustainable, not initial response, and only that we are having it for a longer duration, and it's important for our patients in the favoring the arm of panitumumab plus modified FOLFOX6 versus Viva and modified FOLFOX. So tumor responses appear to occur earlier and sustained longer and deeper for the panitumumab arm versus Viva treatment arm. Another important tool or high-level evidence for our patients in the oncology after the randomized phase 3 controlled trial is the meta-analysis and systematic analysis. And again, we are having a strong high-level evidence that confirms the role of first-line anti-epidermal growth factor receptor compared with the antivascular endothelial growth factor in advanced colorectal cancer. This meta-analysis of randomized control trial by Professor Muhammad Hattar. And it collected more than 13 prospective randomized trials that search for the anti-EGFR versus the anti-VEGFR, and all randomized controlled phase 2 and 3 trials, comparing them in the first-line setting as regarding the overall response rate, progression-free survival, and overall survival. And this force slide showing that objective response rate with the RAS wild type, as we see that selecting the major 3 trials that studied the 2 agents in the metastatic colorectal cancer, FIRE3, PEAK, and HGB trials, it all confirmed the importance and the usefulness and the significantly positivity of the arm using the panitumumab, as well as the progression-free survival was significantly positive in the favor of the panitumumab arm in the RAS wild type, and as well as the most important endpoint, the overall survival point. So the results of this huge systematic meta-analysis confirmed the guidance and the beneficial use of anti-EGFR therapy comparing with the anti-VEGF therapy in both RAS wild type and all RAS wild type advanced colorectal cancer patients. And these results suggest that anti-EGFR monoclonal antibody is real alternative for anti-VEGFR therapy as initial treatment for advanced colorectal cancer. Sequence of therapy, as we said, that now we are having the metastatic colorectal cancer patients who can be curable, who have longer survival. They are chronic patients that now they are having the specific definition, which is the continuum of care for the metastatic colorectal cancer patients. They live long. They need sequence of therapy. And now again, to this important trial, which show the impact of subsequent therapies on outcome of the outcome of the FIRE3 trial. The first-line therapy was FOLFIRI plus cetuximab or VEVA in patients with KRAS wild-type colorectal cancer patients. The purposes of this trial was to investigate the choice and efficacy of subsequent treatment. We are having longer living patients and its impact on their outcome in the FIRE3 trial for FOLFIRI plus cetuximab or VEVA for patients with RAS wild-type metastatic colorectal cancer. And the results were significantly positive as regards the progression-free survival for the anti-EGFR arm, as well as the overall survival benefit was significantly positive for the anti-EGFR arm. So the conclusion suggesting that the sequence of drug application might be more important than exposure, not single agent only. In patients with RAS wild tumor, the first-line application of anti-epidermal growth factor receptors directed therapy may represent a favorable condition for promoting effective subsequent therapy, including anti-angiogenesis agents. The primary colorectal tumor location and efficacy of targeted therapy. The anti-EGFR outcome by the tumor location analysis. The right versus the left side colon cancer, the overall survival benefit and anti-EGFR. And these slides were showing the collectively trials that have studied the sidedness and the primary tumor location, as well as regarding the prognosis and prediction of therapy, all have confirmed that left-sided RAS wild type showing significantly higher overall survival benefit, progression-free survival in the anti-EGFR line. The significant benefit was in the combination of panitumumab in the left side RAS wild type. The second endpoint was the progression-free survival, the same, the right versus the left side, and again the benefit was in the left side with the RAS wild type and addition of anti-EGFR. In the 3 important landmark trials in the metastatic colorectal cancer FIRE3 trial. Another big meta-analysis for the anti-EGFR outcome based on the primary tumor location, the Holsh and Arnold meta-analysis. They confirmed the same results for the left the importance and the addition of benefits as regard as the progression-free survival for the addition of anti-EGFR as first-line treatment for the metastatic colorectal cancer patients with left side and RAS wild type, as well as the overall survival benefits supporting the preferential use of the anti-EGFR plus chemotherapy over VEVA plus chemotherapy for left-sided tumors. And the overall response, it has a unique findings as we are having the positive findings regarding the left-sided wild-type patients. We also found that we have initial overall response benefit for the RAS wild-type right-sided colon cancer patients. And there was no significant difference in the overall survival benefit for the chemotherapy plus anti-EGFR versus chemotherapy VEVA for the right-sided tumor. Side effects. The common question that we are faced by our patients in our daily practice and in taking decisions. And we are having the characteristic side effects for the anti-EGFR, which is the skin toxicity. And sometimes we are, I think, all attendees will agree with me that sometimes we are facing that the patient may refuse to take the treatment, which will affect his outcome or survival because he doesn't want side effects. Patients who are need the good presentation, teachers, patients who are in the media, or patients. We all think that some patients do not want to take the treatment because they do not want side effects, and we are having specific criteria of side effects for this class of treatment, which is the skin toxicity. So we are having a very good. Okay, so is it better to go for skin toxicity prophylaxis? Usually, to go with the preventive approach is very useful. To go for patient education and counseling is very useful. It will keep the patient adherent to his treatment or her treatment and will not stop the treatment and will not affect the outcome. We are having very nice trial, which is the STEEP trial. It's skin toxicity evaluation in a patient receiving panitumumab. This is the abbreviation of this statement that has examined the difference between primitive and reactive skin treatment for the skin toxicities in patients with metastatic colorectal cancer. Let me add something also that sometimes we try to encourage our patients that this skin toxicity is a good marker that you are taking good care of your treatment and you are having the maximum benefit of treatment. But patients, I don't like this skin toxicity, especially the younger patients. So if we have now preventive measures and it's available for free with the medication, we will definitely improve the outcome of our patients. So this STEEP trial was phase 2 multi-center open label randomized trial that offers treatment options, which is not a luxury or fancy that we are offering this supportive measures. It's mandatory and that will help our patients to adhere more and more to this treatment and get more benefit and better outcome. Skin moisturizer, sunscreen before going to outdoors, and we are in a hot country. Topical steroids at bedtime, doxycycline antibiotic 100 milligrams twice daily versus the reactive skin treatment after treatment week 16. As expected, that the patient who received the preventive measures, the group of patients were 95 patients, and as expected, the patients who received the preventive measures, they prevent the side effects and start to adhere more to the treatment. The skin toxicity is defined by the protocols were itching, acneiform rash, skin fissures, skin laceration, pruritic rash, pustular rash, skin infection, and skin ulceration, with the standard dose of panitumumab and the chemotherapy protocol. And the primary endpoint was to determine the difference in the incidence of grade 2 skin toxicities in patients treated with primitive versus reactive skin protocol. As expected, the results was significantly higher in the primitive arm, that it prevents the occurrence of grade 2 skin events or even lower the incidence of them, 29% versus 69% in the reactive arm. The grade 3 toxicity that needs interruption of treatment and stopping to manage the skin effects were almost very low number, 6% in the primitive arm versus 21% in the reactive arm. The median time to first skin toxicity wasn't reached in this primitive group, 2.1 weeks in the reactive arm. Partial response was achieved 15 versus 11 in the primitive and reactive respectively. The median progression-free survival was 4.7 versus 4.11 without any affection for the efficacy of our treatment. This is some slides or pictures for the different grades of skin toxicity and the management of them. Grade 1, we can use just skin topical measures, emollients, hydrocortisone 1% cream. In grade 2, we start to add oral tablets, oral antibiotics. Grade 3, as we said, that we have to stop treatment and start to go for dermatology for treatment. And as we don't want to reach this higher grade of toxicity in order not to interrupt our patients during the treatment. Thank you so much.
Thank you, Dr. Nermeen, for this very informative lecture this overview of use of anti-EGFR and toxicities. Thank you so much.
Thank you so much. Thank you for all attendees to stay late till now. Thank you for Amgen team for inviting me again for this session. And I would love to ensure that the kits are available. Please ask for them with the treatment. And the RAS testing vouchers are available for free. Please ask them for our patients. Thank you so much. Have a good night.